Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast.
Today we're looking at a paper from the June 2026 issue of the Korean Journal of Radiology titled Assessing Treatment Response in Soft Tissue Sarcoma Using Dynamic Contrast Enhanced MRI, a Systematic Review.
Right. Soft tissue sarcomas, or STS, are a tough group of tumors, and one of the real clinical challenges is figuring out if neoadjuvant therapy, the treatment before surgery, is actually working.
It's a huge problem. The standard methods, like RECIST, are size-based. You measure the tumor. But in STS, that can be incredibly misleading.
How so?
A tumor can be responding well, filled with necrosis, but its size might not change, or it could even get bigger due to hemorrhage or edema from the treatment itself.
So the ruler lies, and the gold standard, histopathology, only happens after the tumor is removed surgically. That's too late to change a treatment plan that isn't working.
Precisely, which is why there's a search for a better, non-invasive way to see what's happening inside the tumor functionally. This paper looks at whether dynamic contrast enhanced MRI, or DCE-MRI, is the answer.
So not just looking at the tumor's anatomy, but its physiology. What exactly is DCE-MRI measuring?
At a high level, it's about the tumor's plumbing. We inject contrast and watch how it moves through the tumor's microvasculature over time. It gives us a window into things like blood flow, vessel permeability, the functional stuff that changes when treatment starts working.
Okay, and this paper isn't new research, it's a systematic review. What was their approach?
They followed the PRISMA guidelines, searching across 4 major databases. They started with over 1,000 records and, after screening, ended up with 13 key studies.
Sample size?
All told, the 13 studies included 234 patients, so not a massive number, which is a theme we'll come back to.
Got it. And the quality of these studies?
They assessed it with the Quatis 2 tool. It was a mixed bag. 4 studies had a low risk of bias, but 5 had a high risk, and 4 were unclear. So the evidence base has some weak spots.
That's a non-trivial caveat. And with the studies being so different, could they even do a meta-analysis?
No, they couldn't. The heterogeneity was too great in tumor types, treatments, and MRI protocols. So they performed a narrative synthesis, basically summarizing the concordant and discordant findings.
Makes sense. So let's get into the DCE-MRI parameters they looked at. What were the main categories?
They broke them down into 3 buckets: quantitative, semi-quantitative, and qualitative. Each one is a different level of processing the raw data.
Okay, let's start with quantitative. That sounds like the most complex.
It is. It involves pharmacokinetic modeling to derive these physiologically meaningful numbers. And the star parameter here, consistently, was K-trans.
Define that.
Think of K-trans as a measure of how quickly contrast leaks from the blood vessels into the surrounding tumor tissue. It reflects both perfusion and how permeable, or leaky, those vessels are.
So when treatment reduces viable perfused tumor and vessel permeability, K-trans often falls.
Exactly, and that's what the data overwhelmingly showed. K-trans had a strong predictive performance for treatment response, with high discriminatory ability in several cohorts.
How high?
One study found its predictive performance, measured as the C statistic, was over 0.90, both early in treatment and after it was completed. That's a very strong signal.
That is impressive. What about the absolute value versus the change?
The change in K-trans was also very predictive, but interestingly, the pre-treatment K-trans value was only a fair predictor. It's the response to therapy that really matters.
Right. And K-trans wasn't the only quantitative metric, was it?
No, they also looked at related measures like KEP, which is the washout rate, and VE, the volume of the extravascular space. Those also correlated significantly with how much necrosis was found in the pathology specimen.
I saw they also mentioned a voxel-wise analysis, which sounded clever.
It was a neat approach. Instead of averaging K-trans across the whole tumor, one study looked at each individual voxel. They categorized each voxel based on whether its K-trans increased, decreased, or stayed the same after treatment.
And what did they find?
It was a bit counterintuitive. A higher proportion of unchanged voxels, voxels where the perfusion was preserved, actually correlated strongly with greater tumor necrosis. The idea might be that preserving some vasculature allows for better drug delivery.
Whereas a large fraction of voxels with a rapid drop in K-trans predicted a poorer response. That's a subtle but important finding.
You nailed it. It suggests that just looking at the average change might be too simplistic.
Okay, that covers the quantitative side. What about the semi-quantitative markers? Are those simpler?
Much simpler. These are direct measurements from the time intensity curve, or TIC, without the heavy modeling. Think of things like the wash-in rate, the time it takes to reach peak enhancement, and the area under the curve.
And did these hold up?
They did. They showed consistent associations with tumor perfusion and hypoxia. For example, one study found that a 34% reduction in the wash-in rate was a good marker for identifying pathologic response.
What about the area under the curve? I saw IAUC 60 mentioned.
Right, the integrated area under the curve in the first 60 seconds. That one also showed consistent associations. It's a nice, simple surrogate for perfusion.
So you don't necessarily need the complex modeling to get a useful signal.
It seems not, which leads us to the third bucket, qualitative features.
This is just looking at the curve shapes?
Essentially, yes. You classify the TICs into different types based on their shape. And the results here were quite clear-cut. Type 2 curves, which are these slow, steadily ascending curves without a rapid early enhancement, were very strongly associated with favorable outcomes.
So a lack of that aggressive fast enhancement is a good sign.
A very good sign. Another study put it even more simply. They just used a visual threshold for early arterial enhancement. If they saw it, that indicated a poor response. If they didn't, that indicated a good response.
And the accuracy?
100% sensitivity and 94.7% specificity in that cohort. Deceptively simple, but remarkably effective.
The paper includes some images that illustrate this really well.
Yes, they do. Figure 1 shows a 48-year-old with an undifferentiated pleomorphic sarcoma. The baseline scan shows a brightly enhancing mass with high K-trans values all over the color map.
Right, it's lit up in reds and yellows.
Then, after neoadjuvant radiation, the follow-up scan shows that the enhancement is down, and the K-trans map is now mostly blue than red.
And the bottom line from pathology?
99% fibrosis and only 1% residual viable tumor. A fantastic response, perfectly mirrored by the DCE-MRI changes.
And they contrast this with another case.
They do. Figure 2 is a 42-year-old with a myxoid liposarcoma. Again, you see the baseline tumor. After treatment, the enhancement and K-trans values decrease, but it's a much milder, more subtle change compared to the first case.
At least partially due to the relatively low K-trans at baseline.
Yes, the pathology confirmed 60% residual viable tumor.
A poor response. So the magnitude of the K-trans drop seems to directly correlate with the outcome.
That's the core finding of the review. The functional changes seen on DCE-MRI, particularly with quantitative parameters like K-trans, appear to track very well with the histopathologic truth.
Okay, this all sounds very promising. Maybe too promising. What's the catch? This is a systematic review, pulling from a lot of different sources.
And that is the single biggest red flag. The word is heterogeneity.
Define that. Under what assumptions does this work?
Well, that's the problem. The assumptions are all over the place. The 13 studies used different STS subtypes which behave differently. They used different neoadjuvant regimens, chemo, radiation, both. The DCE-MRI protocols themselves were different. Different scanners, different contrast injection rates, different timing.
And crucially, different endpoints. How they defined a responder wasn't consistent.
Precisely. For some, a good response was more than 95% necrosis. For others, it was more than 90%, or even more than 50%. This makes it impossible to establish a definitive generalizable cutoff value for something like K-trans.
So you can't say a 40% drop in K-trans means the treatment is working, because it depends entirely on the specific context of that study.
You've got it. That's the major hurdle to clinical implementation. There's no standardization.
And the small cohort sizes are a problem too. Across 13 studies, only 234 patients. Some of these individual studies must have been tiny.
They were, and in some of those with very few patients, they didn't find a significant association between K-trans and response, which might just be a power issue.
So where does this leave us? We have a biomarker that seems to work in principle but is too messy to use in practice right now. Is that a fair summary?
That's a very fair summary. The evidence is generally concordant and points in the right direction, but the lack of standardization and the small studies limit our ability to draw firm conclusions.
What's the path forward then? What do the authors recommend?
It's the classic call to action from a review like this. We need prospective, multi-center studies with pre-specified endpoints and, most importantly, standardized protocols.
Everyone needs to be playing by the same rules. Same MRI acquisition, same modeling software, same definition of response.
Exactly. Only then can we validate these DCE-MRI biomarkers and establish the robust thresholds we need for clinical decision-making.
The authors also mention that DCE-MRI doesn't capture everything. It's focused on vascular changes.
Right. A treatment might also affect tumor cellularity, or the stiffness of the tissue. DCE-MRI won't see that as well. They suggest that a multi-parametric approach, combining DCE with other techniques like diffusion-weighted imaging, or DWI, for cellularity, or MR elastography for stiffness, might provide a more complete picture of treatment response.
So build a more comprehensive model of the tumor's biology.
That's the idea. Instead of relying on one metric, you use a dashboard of metrics that each capture a different aspect of the tumor's response to therapy.
Bottom line, for a radiologist reading an STS scan today, is DCE-MRI a tool they should be using to assess NAT response?
It's a tool with enormous promise that provides information that size-based criteria simply cannot. It can definitely show a treatment effect, but without established, validated cutoffs, using it to make a definitive call to say, stop an ineffective therapy is still on shaky ground. It's a powerful piece of evidence, but perhaps not the final arbiter just yet.
It needs to move from an interesting research finding to a reproducible, reliable clinical test.
Precisely. The promise is there, but the engineering work of standardization and large-scale validation still needs to be done.
Let's land this. DCE-MRI, particularly the quantitative parameter K-trans, shows a strong and consistent association with the true pathological response of soft tissue sarcomas to neoadjuvant therapy. However, the field is hampered by significant heterogeneity in study protocols and small cohort sizes.
Which means that while the signal is clearly present, it's not yet standardized enough for widespread, reliable clinical use. The path forward is through large, prospective trials with harmonized protocols.
That's all for this episode of SummaryCast.